All right, so my approach here is advanced imaging. So to me, that excludes most transthoracic. I think most transthoracic echo is still very advanced, but CMS does not. So we'll go with the CMS definition, and we'll talk about mostly other stuff other than transthoracic. Okay, so the objective is really to sort of review briefly cardiac MRI and CT usage, or at least examples for tricuspid valve, briefly discuss some of the expectations that have changed for TEE, which is advanced, and then just briefly introduce some of the imaging challenges for transcatheter therapies. So 90% roughly of the TR that we see in clinic is functional in its origin. And how do we get there? Generally, there's a chronic pathway. It's either AFib, something that gets you left atrial pressure elevation over time, or primary pulmonary. And these get to the two mechanisms of annular dilation and tricuspid leaflet tethering. So some version of those two things. This is sort of just expressed differently, but really when we see the graphic, and almost every functional case has some version of this. Sometimes it's very annular dilated, not a lot of tethering. That would be the atrial TR. Sometimes it's a very tethered RV. But these two mechanisms get us the functional scenarios. So that's what we're looking for when we do the functional imaging. So just to hit the guideline, this has been around for a long time. This is how we quantify TR. It's a bit cumbersome, but I was on the writing committee, so I take a little responsibility for some of that. But when you have the mild TR is easy. When you have at least 4 criteria or so, you have severe TR. But the newest thing that a lot of us are dealing with is more than severe. So we've had these other elements introduced, torrential TR, massive TR. These are sort of falling into the lexicon. They're not quite in the guideline yet. They are in the European guideline. Some would say, why do we need these? Well, in the era of transcatheter interventions, it's not uncommon to start here and go to here, or start at massive and go to moderate. And if we just called all of this severe, you would lose any sort of measures of benefit. So asking the question, is there a mortality or a quality of life benefit in going from torrential to severe, perhaps reducing your regurgitant fraction by 50%? These are why these categories exist, and we're still learning more about them. One of the things in advanced imaging is we have to sort of start to understand the display of the imaging. So this is just a publication that looked at sort of helping us identify the leaflets. So on the tricuspid space, it's a little more complicated than mitral. We don't just have a front one and a back one. We have to sort of figure out septal, posterior, anterior, and understand the views. So we're starting to have sort of descriptions, and they look fairly echo-ish in the presentation of a 4-chamber, a 2-chamber, an inflow, outflow. So sort of recognizing how do we display TR images and how do we think about them across different modalities. I do have to shout out to my own cardiac imaging team at Houston Methodist. They provided me several of the images and slides that I'll show you in a second. So one of the neat things on this particular case is you can see the magnitude, well, the size of the RA clearly, but the hepatic reflux here, the massive amount of flow going backwards. And this is immediately after a TTVR procedure. This is an investigational device. And really, yes, the RA is still enormous, but the immediate hemodynamic effect on the liver is obvious. You'll also see, and it's not an RV focused view, but you might appreciate that the LV gets bigger. So that's one of the things we're realizing. If you take away an enormous amount of TR, you immediately increase the preload to the left side. So in addition to the RV functional changes, which I'll show you, you can expect usually significant LV functional changes. A combination of improved interventricular septal function, but also just increasing preload to the left side. This is an example of the hepatic reflux you see here, and then completely gone right after a procedure. So I said 90% is functional, means 10% isn't. So there are cases of primary TR. So this is an example of carcinoid. You can very clearly see thickened leaflets. They're shortened, retracted. It's the TR we all learn about in med school. It's fascinating when you see it. It's actually hard to miss. It's so unique. We also have tricuspid prolapse, which we see from time to time. How do we measure TR on these other modalities? Well, accurately is the short answer. So the basic way, it's the indirect method. You get the RV size, which is not trivial to do. So actually measuring the disc summation, knowing where to draw the barriers, knowing how to figure out the RVOT, how to get the volume below the tricuspid valve, these aren't trivial things. And when there is variation in the modality, that's generally where it is the RV trace and the RV determination of size. Then you just simply subtract the pulmonic flow. So that difference is what is the RV pump, what hits the PA, that's your TR. And it's very straightforward and it's very reproducible. And frankly, it's more reproducible and generally more accurate than transthoracic echo or any form of echo. This is another case. This is a fairly large person, you can tell by the tissues. Not only do you see the hepatic reflux from this wide open TR, but you see flow way out here. I'm not even sure what that is. It's sort of out here in our chest wall somewhere. This is a very large person. I think the surgeons in Texas call this a Texas medium. But this is, you can imagine where the TR is. It goes everywhere. So it's not just an RA effect. It's a body effect. The other thing we've sort of nomenclature that's really hit recently is looking at not just mild, moderate, and severe TR, but sort of changing the concepts to talk about low risk, intermediate risk, high risk. And this is sort of a graphic and a reference from our center that looks at this, saying if your regurgitant volume is less than 30, probably low risk. If it's between 30 and 44, intermediate. And regurgitant volume over 45 mils is actually high risk. And that's important to know that there's a continuum of risk. So this is that same graphic, and you can see here, if you look at the hazard ratio over tricuspid regurgitation or over regurgitant fraction, you can see that it takes off pretty quickly, and it's linear and it's progressive. So there's not three buckets. It's a continuum of risk, and that's one of the things that we have to get to. A little preamble for the debate to come is, do you wait for everybody until they're in the far high-risk category, or should we be intervening earlier? Now, that's a cheat. I'm cutting into my debate time, so I won't do that now. Sorry, Rhonda. But we also know that the TR severity is a big risk factor in even tricuspid surgical intervention. So again, simply dichotomized on the EF, the RV-EF shown here, and you can see that there's a big difference in your surgical outcomes in the MACE events. So TR is a continuous risk factor. I did mention one of the other forms of primary TR is prolapse. And this is one of the things that we can get from advanced imaging, particularly with CMR. You can actually measure the volume under the leaflets. So this is a concept both for the mitral and the tricuspid. When you have large biliary leaflets like a Barlow's, you actually have a volume that doesn't hit the RA and should be considered TR nonetheless, because it's extra volume that doesn't go forward and it helps to preload the right ventricle. So this a non-regurgitant prolapsing volume is considered, and it's not usually huge, but it can be up to 30 mils or so. So it can be additive and quite significant. And you have to figure out, how do you account for this volume? Doesn't hit the PA, doesn't truly hit the RA, but what is it? It doesn't go forward. And this is a bunch of work that looked at that, and that's important. And you really can't only get to this typically by a CMR. Other stuff, from CMR again, you can get RV free wall strain. Again, does this matter? It can matter. And this is an example, again, just looking at patients with functional TR and their outcomes over time, and it's a nice dichotomy. If a free wall is more negative than less than 16, that's good. Obviously, strain, you want it to be a big negative number. And here we see that value is also predictive. Looking at pacemaker leads and cardiac implantable electronic devices, we have advanced imaging to help with that very much. Here you can see the lead buried in the sort of posterior septal, and you can see it traversing. But really, CT is amazing at this. And the graphic on the right, I'll show you here. This is a patient who has a mechanical mitral valve, a transcatheter delivered tricuspid valve. They have an old jailed lead. You can see it here. This just would have been in the posterior septal groove. It's actually impacted and sort of flexed up the flange of the TTVR device. But then they had the new lead go through the valve. And you can track all of this very easily. You can see the device-device interaction beautifully on CT. It's very difficult to get any of this on a transthoracic echo. You can get some of this on a transesophageal echo, but nothing like this sort of delineation of space. This is another thing, looking at changes over time. So this is a baseline case. Get this to play. All right, so at baseline you have the RV-EF, which is sort of a falsely elevated EF in the setting of wide open TR. The RV stroke volume is 30 mils more than the LV stroke volume. And then immediately after TTVR, the RV-EF goes down. That's not unexpected. The LV to RV stroke volumes are now equalized. So this is a nice example of, again, how we use advanced imaging. And then the other thing we get to is sort of, these valves don't last forever. Things can happen. This is an example of halt. It's very difficult to see here, but here you can see the trace, and you can sort of start grading halt and seeing that level of detail typically on these cases. And then finally, we don't do a lot of this, but it's always exciting to see 40 flow and 40 flow from CMR. You see the diastolic inflow. You see the regurgitant volume. This is difficult to lay there for 30 minutes and have this protocol done to you, but the images are fantastic, and I've been excited about this for 15 years, and I'm waiting for it to become real time for all of us.
Just to quickly close up with some TEE, the expectations for TEE have changed. We've got guidelines on how to do this. This is an advanced imaging. If you don't do a lot of TEE, you have to focus and learn how to see the RV and the TR in detail. Multiple views now expected of you. This is an example. You can't see the detail of all this, but just when you're doing a dedicated TR evaluation, this is an example of the sorts of depth of imaging you must acquire now by TEE to answer the questions. You have to eventually know which is anterior, septal, and posterior from a transgastric, the only view in 2D that shows all three leaflets. And then we start thinking about how to do these procedures. This is quite similar to the case that Linda showed. And then we use a lot of NPR, so I guess this is advanced. And NPR we're using more and more because the probes are better, the software is better, the tissue resolution is better, the temporal resolution is better. So if you tried NPR 5 years ago and you didn't like it, that was a different experience. It's actually better now than it has ever been, and we're using it more and more. Again, this is sort of why we do this imaging, is to see the difference. ICE, advanced imaging, we are doing more and more of this. I'd say now we're probably up to 50 to 70% of our tricuspid interventions use adjunctive ICE, so still TEE, but we're adding in more and more ICE, particularly when there are implantable devices to see around. The other sort of modality, this is a severe secondary case, and we've heard a little bit about these already, the TTVRs. This is the MPR, multiplanary reformatting, MPR. Let's keep going here. The acute changes after a TTVR procedure. And then sort of going through, as Dr. Gillum showed, evoke, and all the different ways to image that. So again, echo is not excluded from these advanced concepts for TR evaluation. We're now in this era where we can see things really well, we can quantify well, we can prognosticate well with all these modalities. We have choices to make now, medical therapy and then TTVR or TEER. Trick valve is coming, or trick valve is in trials now. This is when you have to abandon all hope for the RV and the TR and the annulus and move to the cava. Basically when things are so big or so bad, or this perhaps might have been an option for somebody who has a single deployed mitral clip like we saw in the case, a valve in both cava. This is just a TE showing the IVC-RA junction of a trick valve deployed, and then the SVC-RA junction. You can see the valve in long axis and short axis. So finally, advanced imaging for TR. Transthoracic echo is still the first line, and I think probably always will be. CMR is really excellent for RV size, function, and for TR volume in a very reproducible way. CT is excellent for RV size, RV EF, and for any electrical devices you want to sort of delineate. 2D, 3D T is required, and I think to understand the mechanism of TR and to select patients appropriately for transcatheter interventions, that's a very established protocol. It takes a bit of work. And then 3D ICE is adjunctive for all transcatheter repair procedures. So I'll stop there. Thank you very much.